General practice, we're here with the TPP GP Excellence Awards, and in this episode we're covering two key aspects of care that is delivered across various different practices. That includes long-term condition care and excellence in GP prescribing. As I'm sure you're aware, important parts of what we do in general practice. In this episode, we've got three different practices showcasing what they've done for those different awards. We're going to showcase what they've done, how they've done it, and how potentially you could do similar if you wanted to, as we tech enhance your primary care and learning. Hello, GP learners, welcome to this episode where we're really happy to bring you the second in our series of the TPP GP Excellence Awards, showcasing the amazing stuff that practices are doing out there using SystmOne to help practices and their patients in terms of navigating general practice. And in this episode, we're talking about two key areas, which is prescribing and long-term conditions care. But just before we get started to introduce you to these amazing practices that are doing all that stuff, we do have some really positive news to share with you, haven't we, Abby?
Yes, no, we definitely do. So Dr. Gandhi is going to be announcing who the two latest winners were for our previous awards. So go on, Dr. Gandhi, I'll hand over to yourself.
Awesome, thank you. So first, last time round, we had the Access and Triage Excellence Awards, and really happy to announce that Chris Hollyoak from Harewood Medical Practice won that award, showcasing what they were doing, particularly for their populations looking after local to their army base and how they're navigating patients with deprivation challenges and stuff, and really happy to hear that they won that award. Congratulations to the other providers who were also demonstrating at that time. This was voted for by you, the public, and you'll have the same opportunity to do that for these upcoming two awards that we've got in a second. But in addition to that, we also showcased the Operational Efficiency Awards, and that went to Mo Bamani from Leyland's Medical Centre for the work that he was doing in terms of utilising SystmOne core aspects to help navigate triage in a different way, but that organizational structure within the practice. And again, that was voted for by yourselves, and you have exactly the same opportunity to do that for our upcoming award categories. Just to mention, each of those clinicians are going to get £1,000 offered by TPP as a result of winning that award for them and their practice to utilize and stuff. So yeah, awesome. And congratulations. Yay. So we're going to get cracking now and talking about the further awards that we've got here today. Just to showcase, if you did want to vote in the particular awards that we've got today, I'm just going to showcase what we've got coming up. So these are your opportunities to submit further entries as well as to vote. And I will put the links to the voting shortly in the chat, and they will also be pinned to the comments as well for the YouTube videos and stuff. And there's also links there for terms and conditions as well if you want to. And we are still taking entries for our next awards, which is the Innovation in General Practice, that will be after Easter because it's busy with Easter and all that kind of stuff. So you've still got plenty of time to submit your opportunities to win those particular awards that we've got in our next upcoming live stream. Anyway, at this point, what we're going to start doing is go through our showcasing excellence in long-term care for, excellence in caring for long-term conditions. Now, you can see we've got a variety of people joining us here. We're going to go to each in turn in a second, but just before we do, it probably is worth we introduce everybody. So I'm just going to go in screen order, if that's okay. So Rich and Rebecca, do you want to say hi to everybody and tell them where you're from?
Hello, we're from the Ridings Medical Group in East Riding.
Thank you. You've already heard from Abby, who's speaking from TPP. Will, do you want to say hi?
Hi, I'm Will. I'm managing partner at Topsham Surgery in Exeter.
And Will's joining us for the second time after getting through to a finalist for the Operations Award last time round. So definitely doing well. In fact, he's been nominated for 2 different awards. Say hi to us, Hannah.
Hi, so I'm Hannah. I'm one of the salaried GPs at King's Medical Practice in Normanton, West Yorkshire.
Thank you. Daniel.
Hi, Daniel Halsworth, the Digital and Transformation Lead for Bytes PCN in North East England.
Thank you. Steve.
Hi, I'm Steve Murdoch. I'm the Digital Transformation Lead for Nottingham West PCN.
Thank you. And Robin, finally.
Hi, I'm Robin, Lead PCN Pharmacist and Partner at Beacon Medical Group in Plymouth.
Okay. Thank you, everybody. So we're going to hear more from each of those in turn as we go through the various different innovations and things that each of these practices and groups have been doing to help in terms of managing the two key aspects in terms of long-term condition care and prescribing. As I said, we're going to start off first with the Excellence in Caring for Long-Term Conditions Award. And first up for that, we've got Hannah. So what we're going to do, I'm just going to take everybody else off because it's going to make it a bit easier for people to see. And just to explain the format for everybody, so each of the practices get 5 minutes to showcase what they've been doing. I'm going to go through the opportunity to ask a couple of questions from myself or from whoever's joining us live in terms of watching. And then we're going to go through that 5 more times. So, Hannah, the floor is yours. Your slides are up and your 5 minutes starts now.
Thank you very much. As before, my name is Hannah. I'm one of the salaried GPs at King's Medical Practice based in Normanton, which is in West Yorkshire. We're a single site practice with just over 14,500 patients, and our full team is just under 50 staff. We're one of the largest training practices in the Wakefield area. So today I'm going to be talking about how we use SystmOne to redesign how we're delivering the cardiovascular disease prevention. So CVD prevention is a major NHS priority at the moment. And there's obviously the current push for digital transformation. So we're all being encouraged to use our systems better, which does sound great until you're halfway through a busy clinic and you're trying to remember where everything actually is. So in reality, what we were seeing was different clinicians were managing the same conditions in different ways, depending on how they work or what they remembered in the moment. There was miscoding leading to incorrect recalls, variations in how treatment was started and optimized. In an increasingly busy general practice, a lot of care was also reactive, relying on opportunistic review rather than being proactive and systematic. So overall, patients weren't really receiving evidence-based targets, not because we don't know what to do as clinicians, but because there was the need for us to deal with so many issues with tight timings and appointments. The system just wasn't supporting our team effectively. So in response to this, we developed an integrated CVD prevention hub within SystmOne. This brings together lots of different factors like lipids optimization, hypertension management, wider cardiovascular risk factors linked with things like diabetes and CKD. We also did some case finding of hypercholesterolemia. It's built entirely using SystmOne functionality. So instead of trying to remember guidelines mid-consultation or having to access external systems, the system quietly supports in the background. It uses protocol-driven logic to automatically identify high-risk patients. It supports clinicians with guideline-based next steps, including safe and consistent prescribing and medication optimization. It standardized how we filed all our abnormal results and how they were actioned. It allocates work across the MDT so that the right work goes to the right person at the right time, rather than everything just defaulting back to the GP. Once the clinician has actually made a decision, the prescribing is then streamlined within the workflow. So this supports early identification of high-risk patients and shifts care from a reactive review system to a proactive risk-stratified population health management. And importantly, it's designed as a decision support tool in itself. It's not decision-making, it's not AI, so the clinician remains in control at all times. So these are just a couple of examples of what it actually looks like in practice. The same approach is applied across multiple different cardiovascular pathways, identifying patients and prompting safe next steps. So rather than clinicians having to rely on memory, it's built into the actual consultation, into the results handling and the wider workflow. And the impact has been both clinically significant and operationally transformative. And more importantly, we've actually felt the difference in our day-to-day appointments. From a workforce perspective, pharmacists are now delivering over 400 additional lipid optimization reviews a year, and we've seen a reduction of around 60 GP appointments per week. This frees up capacity for more complex care. Physicians' assistants and healthcare assistants are also playing a bigger role in structured hypertension assessment. It also supports our admin and care coordination teams by generating clear, structured outputs so they know exactly who needs contacting and what needs to happen next, which I really do find reduces the back and forth chats and conversations, and it makes the whole process much more efficient. Clinically, we've actually seen a 628% increase in secondary prevention target patients reaching their lipid targets. Over 1,400 patients achieving those non-HDL targets this year, and more than 1,000% increase in primary prevention target attainment. And I think these figures really speak for themselves. We've seen a 24% increase in our diagnosed hypertension rates, a 27% increase in patients achieving blood pressure targets, and we've also identified an additional 61 patients as possible familial hypercholesterolemia. Overall, this means significantly more patients are now receiving evidence-based treatment to reduce their risks of heart attacks or stroke. And what makes this work different is we didn't introduce any new software to do this. We use SystmOne functionality to build a system. It enables proactive, systematic and consistent care across the practice. It's cost effective, and it did require an upfront build, but there's no additional software to that. It's scalable and it's easily reproduced across other practices. And it also supports safer adoption of new therapies such as inclisiran by helping identify appropriate patients early and ensuring the right tests and follow-up are arranged. But most importantly, it embeds clinical safety into everyday workflows, which on a busy day makes a real difference. To put it simply, it just makes doing the right thing that little bit easier. And the final result is a safer, more consistent cardiovascular care for thousands of patients. Thank you for your time.
Thank you very much, Hannah. So in terms of questions I've got, it sounds like amazing work that you've been doing. You mentioned that initial setup build time. What would you estimate that to have been in terms of the amount of effort? And I can see that you mentioned there that your practice was 14,500 patients. So hopefully give a rough idea for other people who are looking to adapt and extrapolate.
Yeah, so it was really a natural process. It kind of grew organically, essentially. So rather than having one kind of big upfront build that we did, it was a slow build of processes and tweaking along the way, essentially. So it's more of a case of we've spent the past kind of year and a half building it, but that doesn't mean it takes that long to build in itself. To actually rebuild the system, if you were to use the protocols that we use now, you'd be talking a couple of days work essentially to build it, to the actual structures of it as such. But in itself, it has been a larger process just because the thing has grown organically over time.
And you shared the outputs you saw in terms of the impact that had on patients. What would you say was the key benefit you saw as a practice team in terms of doing this work?
So it's really helped the team in general because it's helped with multi-layers essentially. So the admin team all know exactly where they stand. They all know exactly what they're doing essentially because there's outputs within the new journal essentially. So they know exactly which type of slots to use to book patients in for, how long to book them in, timeframes of waiting essentially. And it gives them lots of advice from that side of things. It supports them when they're processing those when everyone brings in their little sheets of blood pressure readings. It supports them when they're entering the data from those as well. So it means that if there's any questions, it tells them what to do, and it looks at nuance as well. So it looks at things like frailty as well. So trying to adjust targets and parameters for palliative patients as well, LD patients. It really breaks down the cohorts to try and make sure that even though it is a system-based approach, it's still giving individualized care for each person.
And I guess with that, I heard lots of things that I can imagine, particularly from the CQC perspective of safe, caring, effective, well-led, etc. Loads of touch points in terms of that and stuff. But if you had to go back and do it again, you mentioned it being a 1.5-year journey to get to this point. What would you have done differently?
Well, it's tricky because when I first started it, the national lipid guidance wasn't there. So I was essentially working from BMJ best practice to build protocols, trying to work through what is considered the best evidence. And then all of that changed when the new national guidelines came out, essentially. So then we realigned to that. So I think for me, it would have been having, if I was to do it again, it would have a clear protocol structure before building, rather than kind of having to tweak things as we go along. But that, as I say, it's already been done because there is already a really clear structure now as to what to follow.
And with that, I know that there are some QOF changes planned as part of the new GP contract, particularly when it comes to cholesterol management. So definitely an area that may need a little bit more tinkering, but it sounds like you're definitely on the journey there to help with a lot of that for your patients and absolutely for your practice teams as well. Thank you very much, Hannah. It was really awesome work and stuff. And what we're going to do now is pass over to our next group. So that's going to be Richard and Rebecca coming on. And got you here both. Just brought your slides on, he says. No, I've got to remove the other one. That's why. There we go. Awesome. There you go. So this is Richard and Rebecca joining us from Riding's Medical Group. The floor is yours. Take it away.
Thank you very much. I actually find it quite difficult to narrow this down. SystmOne and Ardens have become so embedded in how we work across the practice, particularly in long-term condition management. So rather than focus on one thing, I thought I'd talk briefly about what we're doing more generally, a few examples, some of the principles behind it, and then a couple of minutes on the thing I found most exciting, which is a tool we've developed looking across multiple long-term conditions. The principles that guide this work are efficiency, uniformity, quality, and patient safety. A lot of what we're doing with SystmOne, using things like clinical reporting, protocols, templates, and batch reports, is really about embedding those principles into the system itself, which fits quite neatly with the NHS 10-year plan and the shift from sickness to prevention. I'd like to say as well that none of this happens in isolation. It relies on our strong admin systems, great team, and support from the wider partnership who've given me time to do this, to actually make this work in practice. So the things we've been doing. After a practice merger, we felt we had an issue with outstanding medication reviews, up to about 12,000. We approached this using SystmOne clinical reporting, but also by rethinking what a medication review actually is, more of a process than a single event. For example, a patient on thyroxine who's had appropriate blood tests and is stable has effectively had their medication reviewed. So we've built a system that recognises when different monitoring criteria are met across medication groups and combines these data points to identify when a review has effectively been completed. Using that approach, we reduced outstanding medication reviews from around 12,000 to 5,000. We've also used SystmOne to run a number of smaller projects, often quite simple things, but with a big impact at scale. One example is using clinical reporting to identify patients on B12 injections who could switch to oral therapy. Using batch messaging and support from our prescriptions team, it took about 1 hour's work, and we ended up releasing over 1,400 healthcare assistant appointments a year. We've also built a number of safety-focused protocols using the clinical reporting, batch reporting, and task templates. For example, we now get prompts when a patient is pregnant and on thyroxine. We get alerts around lithium toxicity and safety nets for things like PSA or thyroid function tests where lab reference ranges don't always apply, such as in finasteride use, pregnancy, or a previous cancer. We've also added prompts for things considering the impact of changing smoking status in patients on antipsychotics due to the impact on drug metabolism, and for patients with a genetic cancer risk to support better decision-making in consultations. Individually, these are quite small interventions, but together they create a much more consistent, safer system that supports clinicians to do the right thing at the right time. Another area we focused on is high-risk medications, things like opiates, benzodiazepines, Z-drugs, and gabapentinoids. Using SystmOne clinical reporting, I've built a matrix of searches to identify patients at higher risk, such as patients on multiple high-risk medications, those with a history of substance misuse or self-harm, and those patients with frailty or polypharmacy, which brings together a cohort of patients where prescribing risk is higher. We then use protocols to act on that. Slide 3. One is an alert to clinicians when they're consulting with or prescribing with these patients, which you can see the sort of nuts and bolts of here and what comes up. We obviously exclude palliative patients from that. We've identified a smaller number of higher risk patients, which is around 50, where we send regular updates to their named GP to support continuity and make sure they're not falling through the gaps. So again, it's about using reporting to identify risk and protocols to ensure safer, more consistent decision-making, particularly for our most vulnerable patients. Another area we've embraced is the pathology auto-review rules engine, which has been a big enabler for long-term condition management. We get about 50% of our results auto-reviewed, and we've then extended this using protocols, task templates, and batch reporting, which integrate well with our QoF processes. So rather than just filing results, the system actively supports clinicians to take the right action. For example, when filing pathology, it can prompt a clinician to quickly code and initiate management for new diabetes or pre-diabetes. It can highlight the patients needing primary or secondary cardiovascular prevention, either starting or increasing. It can support CKD coding and management, including abnormal ACRs, identify patients needing gout optimization, and help with interpreting abnormal LFTs. So it's not just an automation, it's structured, consistent clinical decision support. This is particularly useful for trainees, where it adds an extra layer of safety and acts as an educational tool, but also improves uniformity and efficiency across the whole practice. Helps avoid unnecessary appointments. We've all seen those patients brought in to discuss a test result that could have been handled remotely or particularly over text. We're using batch messaging alongside this, for example, automatically sending cancer safety netting information after a normal fit test, encouraging patients to represent if symptoms persist. So sorry, that was a bit of a whistle stop. The thing I really want to focus on is something I've called the all-in-one case finder. The background to this is there's hundreds of searches within SystmOne and Ardens identifying patients where there's an opportunity to improve care, but it's just not realistic to work through them all. So I've tried to bring a number of these together into a single quick activity. This is built using SystmOne protocols linking into clinical reporting, templates, and task templates, all with those same principles in mind and very much aligned with the NHS 10-year plan, particularly around prevention and reducing future acute demand. What we now have is a protocol that runs for certain staff on opening a patient record, takes a couple of minutes, which you can get down to under 30 seconds once you're familiar with it, and can trigger a range of actions. Like, in practical terms, it looks like this. Patients needing an osteoporosis risk assessment, which I'll show here. Ardens estimates we've got around 12,000 patients who could benefit from this, so doing this opportunistically is really the only feasible way. Identifies patients with osteoporosis not on treatment, patients who may have gout or hypothyroidism but aren't coded correctly, so not getting the right monitoring. We've also linked in some respiratory work by adding a protocol that can identify patients with high inhaler use or those on inhalers without a diagnosis and prompt appropriate review, helping us pick up poorly controlled disease and prevent exacerbations. All of this is about embedding proactive care into routine activities. In terms of outcomes, just looking at my own use over 12 months, entirely opportunistically, I think that pops up. I've done 473 osteoporosis risk assessments, 52 new hypothyroids coded, 16 gout patients coded, and 50 patients identified as high salbutamol use and brought in for review. We've also increased our asthma diagnoses by 48% and COPD diagnoses by 75% when comparing the last 2 years. So this is very much prevention in action, identifying unmet need, improving long-term condition management, and reducing future risk. I think I'll manage to show you some of the clinician-facing aspects of the protocol, which should be slide 10. There we go. And one small but useful feature I've used is if we use clinical templates, we can use them not just for data entry, but quickly review relevant historical information. For example, being able to instantly see previous fracture history when assessing osteoporosis risk. So overall, this is really about using SystmOne, not just to record care, but actively drive it, making it easy to do the right thing for the right patients. Thank you.
Thank you. Awesome work there. And it sounds like you guys have spent loads of time creating loads of work. And yeah, can definitely see that with those mind maps of the protocols as well. I guess in terms of questions, so that looks like a huge amount of work, if I'm being honest. And I saw there, obviously, your practice is quite large, 47,000 patients, if I remember rightly. Yeah. How did you share how you managed to do all that work with the staff to manage that? Again, 250 staff members, if I remember rightly. I appreciate not all of them will be using all of those aspects, but that's a lot of stuff to communicate and share. How did you go about that?
We've got some really good processes already running. I sort of think about it as the under the bonnet work. You know, that we've got really good recall systems. Which we've sort of reviewed as we've proceeded with this, and the long-term condition work that we're doing in terms of using Ardens for our reviews. So there's a lot of things that when we're building these things is hooking into the things that we're already doing and using the processes that are already in place. We have regular clinical meetings so we can update people with things there. So we're trying to use that side of things. The medication review aspect was the thing I did first, and we did this after we'd merged, and it was a really useful element, something that I was building, in that it helped me understand really well what's going on in the different teams in the practice, particularly as I was joining the larger practice at that time. So helping understand what happens when a patient's not collecting their, what happens when a patient's not turning up for their recalls, because we're relying on the fact that we can get hold of patients to bring them in for their long-term condition management and understanding all of those things. So I suppose it's relying on those structures. In terms of the time taken to build a lot of it, I'm quite fortunate in that I do have some admin time built into my rota to do all of this as part of a clinical governance role. So getting that support's really useful as well.
Awesome. And in terms of time, I mean, again, seeing those maps of the protocols and that kind of stuff, how long did it take?
I don't know. I don't think it's as long as you think. Once you get comfortable building protocols, I found that when we were doing the auto review rules, that took forever. The auto review rules took ages, and you can see that Ardens has now built much better ones, and SystmOne's updated it so that you can now use the lab reference range, which didn't exist when I started building my rules. So trying to cross-reference the fact that there was 2 different labs across the sites and trying to come up with reference ranges that were suitable for everybody, that made it a lot trickier. But from that, then building the protocols, thinking, okay, well, say I've got a patient I've got this HbA1c. This HbA1c is the second one above 48 in this particular time frame. What do I want to happen? I want diabetes coding, so this patient's on that list. I want an appointment arranging with the nursing team. I want this or it. and trying to build that into protocol so that all happened in a uniform, efficient manner, rather than somebody not knowing what they're doing and adding extra appointments that weren't needed, or not coding it and then that patient getting lost. Once you start building that into a protocol and you get more comfortable with protocols, you can actually build them fairly quickly. It's just getting comfortable building protocols. So I think it grew from there. So it's one of those things that, you know, you get an idea from a guideline or from a podcast and think, right, what are we doing on that, about that, or responding to a significant event. So the lithium pop-up was, we had a patient who something could have been done sooner. So now any patient who's on lithium, you open the clinical consultation, it says, by the way, do you know this patient's on lithium? And I'm sure you do remember what the signs of lithium toxicity are, but just in case you haven't come across that patient, you know, I think we've got about 11 patients on lithium across our 48,000 patients.
Yep.
Here's a few reminders so that when you do see that patient with diarrhea who's on lithium, oh, should I be thinking about that rather than just saying it's a viral gastroenteritis? So I suppose it's thinking about those things and putting it all together. So plenty of time, but not necessarily as much time as you'd think. And I think you get the time back from the savings.
Thank you. And last question quickly, where would you say if somebody wanted to get started doing some of this work and looking at that thinking, oh my gosh, that's too crazy, where would you say they get started?
I think be lazy. So I always say that there's a very fine line between laziness and efficiency. And there's an old saying about get a lazy man to do a job first and see how he does it. I think start identifying things that you're doing regularly and think, how can I save time there? How can I automate that process a bit? Whether that be starting building some SMS presets or something like that, starting engaging with the things that are already in SystmOne, or having that idea about quality improvement and say, okay, I wish I could do this thing that improves care, but I want to do it quickly and efficiently and the same every single time. So when a trainee comes, I want them doing the same as the senior partner. And start from that, get the ideas first, I suppose, and start playing. It's quite fun to play on some of the reporting tools and things on SystmOne.
Awesome. Thank you very much. And thank you, both of you. I'm sure people are looking at it thinking that is awesome. However, we still have one more category to go through. So I'm going to bring on Daniel now, and he's going to go through his section. So let's just swap this round. So Daniel's joining us from Bytes PCN. Your slides are up, Daniel, and the floor is yours. Take it away. You're on mute, Daniel. Sorry. I've just, yeah, there you go.
Yeah, there we go. My screen, sorry, my screen shared over it quickly before I had a chance to switch. Yes, so Daniel Halls with the Digital and Transformation Lead for Bytes PCN. We have 4 practices and 5 sites and 53,000 patients with quite a varied demographic. The challenge I'm going to talk about today landed with the new asthma guidance when that came out, and that pretty much started some discussions across our PCN and practices as to best practice and what we've got going on at different places within our PCN. And we quickly realised it was a bit fragmented, inconsistent. We've got a lot of people relying on certain people within the practices, and when they weren't there, we realised it's probably a bit too dependent on individual clinicians. So we took a step back, and rather than looking at the bigger picture, decided to drill in really into the actual processes. I wanted to create a system that would make asthma care for us more consistent, a little bit safer and more proactive. I've spent quite a bit of time becoming more familiar with tools within SystmOne. So what I'm about to talk about uses quite a big combination of reports, visualizations, presets, task templates, protocols, numeric driven workflows as well. So I like to call it if this, then that. The way I decided to approach this was, if this happens, or if a patient's in this situation, I want that to happen. And now that's where we started. So we automatically flag new registrations with an asthma code but no objective tests when they register, to help improve the risk factors using the reporting or incomplete diagnostic data, just to try and help make sure that no one falls through the cracks, or that we're offering those appointments to people to confirm that diagnosis before our clinicians go on to continue prescribing things they may or may not need. A diagnostic support tool to help these clinicians with all this new guidance, all the things that we're looking at, there's a preview of that you can see here. Try to bring together everything that might be indicative of asthma, from ATP to your eosinophil count, other medications, respiratory disorders and observations. So we're looking at, have they had recurrent chest infections or other things, or other tests, peak flow tests at their previous practice that might help that diagnosis criteria. And when we've looked at all that, the clinician might kick off by coding suspected asthma. And then what we do is we use a combination of protocols. These include pop-ups, automatic prescribing, appointment invitations, something that overall has become a bit of an ecosystem, or the suspected asthma pathway. To briefly talk you through that, to code that suspected asthma, and the clinician is automatically faced with guidance as to whether they want to be looking at the pheno or the spirometry route. They'll be provided with the links and that to send the patient a direct invitation and booking link to reduce the admin time further. In that booking link, the patient's also provided with information to prepare for their appointment. For example, we don't want another patient walking in after immediately smoking a cigarette into their spirometry appointment. As part of the process for one practice, it will automatically then trigger a prescription for salbutamol and the spacer. That'll take you down 2 different paths depending on whether it's for a child or an adult, so you don't get to the appointment and you've got the wrong size spacer. So all of this is working to reduce the admin burden on the clinicians and the admin staff, manual tasks, different approaches, who can do what and who to book in with, because those self-booking links are into dedicated slots, so we know they're getting booked in with the right person. Skip forward a bit to that test taking place, and our system will automatically generate an interpretation task. They've got age-specific thresholds attached to them. So we know that the clinician receives the right prompt for the next steps and that they're interpreting them with things like age in mind.
Sorry to interrupt, Daniel. I'm just aware you're clicking on screen, but we're not seeing anything moving. So I don't know if you were under the impression.
Oh, sorry, it's my notes that are built into it. I have to scroll through them.
Okay, apologies.
Sorry about that. So that's to obviously aims to reduce errors and speed up the decision making. And then we've got 2 pathways that come off of that. If the asthma is confirmed, it's going to automatically add a recall for their annual review in 12 months. It's going to launch the appropriate adult or child template, depending on their age, and provide you with some treatment guidance. Skip forward again to the annual review. Depending on the outcome of that review, for example, if we detail poor inhaler technique, we're going to automatically send that patient a guide on using their inhaler without that clinician having to dig around and find the link that they might not have sent for a few months. When they code the annual review, the recall's automatically going to be moved on, potentially without any manual input from the clinician, unless they want it bringing forward sooner to see them again in 3 months following poor management. The other option, whereas if the asthma is excluded, the patient receives an automatic message to let them know that there's no further action needed and the pathway closes pretty cleanly. So I talked through the inhaler technique and the poor adherence, but some of the next steps that we'll be looking at is linking this with the MART therapy. Sorry, a couple of clicks there by accident. And automatically writing the asthma action plans as part of the review based on what they're prescribed. That will hopefully then just generate it, print it, or give it to the clinician digitally for them to send direct to the patient via SMS, not just improving the efficiency and time for the clinician, but associated printing costs as well for the practices. So I think overall we can definitely say it's an improved pathway, lots of automated elements in there that are all specific and native to TPP. There's nothing in there that's external. Lots of feedback from people saying that they really, really like it, and that's where the next steps have come from. The idea of adding on the asthma action plans towards the end of it was following the implementation of the initial pathway and positive feedback and wanting to adapt and build on it. And my favourite part of it here is this just helps people to realise they don't always need to remember that pathway. Lots of guidance comes out, it's confusing, it's a 150-page PDF. We don't always have time to go through that and check and remember. So ideally giving something to them that remembers or will prompt them with what they need to know, and something that we can update based on when any new guidance comes out as well.
Thank you. Well done. You okay there, Daniel?
Yep, sorry, my screens have gone all funny and split and I can't find the stop sharing button.
That's okay. I'll take that off for you.
Thank you.
Thank you for that. Really interesting. And you mentioned quite a few different stages that came through in terms of the work that you prepared. Also, you know, the amount of thought that's gone into that in terms of particularly the parts that jumped out to me, thinking about, you know, patients who's smoking, to make sure that they're advised not to do that before they come for the spirometry and the impact that might have. What would you say was the biggest lesson you learned from going through this process, and how you kind of improve that?
Involve as many people as you can. Although I'm totally non-clinical, having conversations with my clinical director, who's a GP partner, but then also the nurses, the ones on the ground delivering this. Without them, is it doing what it needs to do, or is it just ticking a box? And where the real effects come in when we're speaking to the right people and really dealing with the issues that they're facing every day, not just from a higher level.
Okay. And in terms of setting this up, particularly using the SystmOne features, which did you find easiest and which did you find the most challenging to do?
I think it was mentioned earlier, it's become a little bit more au fait with everything. They all tend to get a little bit easier. I probably spent longer getting to grips with visualizations. But the way that this one works is a bit more like a jigsaw. It's lots of little components that come together. So a 2-minute protocol here, a 5-minute report there. But when you put that all together, it adds up. So yeah, I would say the protocols are my favorite. I enjoy those. And I think the visualizations tend to be the head scratchers. Okay.
Thank you very much, Daniel. Really awesome work there. And I guess if people do want to vote for Daniel, feel free to do so. We absolutely have amazing work that all the providers have been showcasing here. And if you do want to vote for them, so I have put the links to that in the show notes below. So if you're watching on Facebook, YouTube, etc. Alternately, you can type in this link. It will be on the show notes for the videos as well. So it can be clickable from there, because I can appreciate it's a bit longer. Alternately, if you want to scan in this QR code that's here on the middle of the screen, you'll be able to do that. That'll take you straight to the voting form, and you can vote for our providers that are looking at hopefully winning the long-term condition care award, and hopefully joining Chris Holyoke, who won our access and triage award and took away £1,000 from our last session. However, we've got more to go. So we are now going to get cracking with our gold standard prescribing award. And we've got 3 other providers coming through to showcase what they're doing. So I'm going to bring up our first nomination, which is Will from Topsham Surgery. How are we doing there, Will?
Yeah, all good. Thank you.
Awesome. So let me bring on the work that you've been doing. And I think this is going to be awesome, but I will leave you to it. And your 5 minutes go.
Fab. So I'm Will. I'm the management partner at Topsham Surgery in Exeter. We're a 12,000 patient practice across 2 sites with a higher than average elderly multi-morbidity population. I'm going to show you our optimized medication review template, or the OMR template as the team call it. So this was our previous process. So the admin team would issue repeat prescriptions. They'd get a warning that it had met the review date, at which point they would then book a medication review with one of our pharmacists. The pharmacist would go to carry out the medication review and realise that there was monitoring outstanding, blood pressures, and they would task it back to the admin team to arrange the monitoring, book it in, and then rebook the review. The system for meds reviews became clogged quite quickly, and we were at a 6-week wait for a medication review appointment with the pharmacists, and it meant that that was pretty much all they were doing day in, day out. It also meant we weren't able to utilise their skill sets because they were just doing the meds reviews, so weren't able to take on as much from the GPs for hypertension and lipid management as they'd probably like to. So we set about reviewing our processes, and it was a case of looking at what can we do better, or do we need to actually employ more staff? And we were looking at employing another part-time pharmacist to cope with the workload. So what we needed to do is look at how can we ensure that all the monitoring is completed before the meds review is booked, or when the meds review is booked, it's at least in the pipeline to avoid that back and forth over task, duplicate appointments and delays. The admin team are amazing, but we couldn't expect them to know every drug and the monitoring that's required for it. So we set about and built a template, which is built on 200 reports in the background. These are linked to status alerts, traffic lights, and it tells the admin team what monitoring is needed, blood tests, etc. Who can do the medication review within our pharmacy MDT. So we've got brilliant pharmacy techs, pharmacists and specialist CVRM pharmacists, and whether there's already appointments booked to prevent that duplication. So this is what the template looks like. So at the top, we've got the initial traffic lights, which tells the team are bloods or blood pressures needed before booking the review. It then tells them what's needed. And this is really useful, not just for the admin team, but also our phlebotomists and HCAs at what test sets to request on ICE. It shows them what upcoming appointments, and from there they can amend them, add on a blood test if needed, cancel them or rebook. Who can do the meds review once all the monitoring is done. And within that, we've linked in preset task types, which will automatically go to the right person. And finally, once the monitoring is complete and ready to book, just reminding them who can do it, and it gives them that green light to go ahead. The reports in the background that feed all of these alerts look at they look at different drugs, conditions, whether or not the patient is in a care home, just so then we can streamline to the most appropriate pharmacist or tech to carry out that review. In the time that we've implemented this, we've increased the number of medication reviews in a 6-month period by 52%. And the average waiting time to be able to book an appointment with one of our pharmacists is 1 to 2 days. So we've not increased capacity in terms of people, but we've massively released additional capacity from these efficiencies within the prescribing team. And this is some feedback from the team that we gathered at the time. So tool is amazing. They're using it all day, every day, and wouldn't want to be without it. It's freed up capacity within our remote pharmacy team and less queries back and forth. Using it when doing prescriptions, but also when doing bloods. And this is someone who's got a dual role. And then from our pharmacist, it's much better. Monitoring is usually up to date. And the beauty is we've been able to tweak it as well. So as we've had feedback or there's been new enhanced services for shared care, we've been able to tweak the tool to add in the monitoring for these different drugs. Or as there's an MHRA alert, we can tweak it and add it in. So it's really become part of the day-to-day kind of practice process, and it's made training new staff much easier as well, because there's a completely consistent approach with all the information that the team might need.
Thank you very much. Let me just bring that back off. Sorry, it's slip around. There we go. That looks better. Can see you now. Awesome. Thank you, Will. So the OMR looks amazing. How can somebody start doing that in their practice?
So it probably took 2 days all in all to do. So it was a few kind of blocks of time and sign off, and we involved the whole team. We started off by looking at the SPS, so all the monitoring that is recommended, had a look at what Ardens are doing, had a look at kind of CQC best practice searches, built it from there, and then did the status alerts, so kind of categorized everything into using E's, LFTs, blood pressures, made alerts off the back of that, and then created the views, and then put all of that into a template.
Mm-hmm. And what did you find the most challenging part of that process?
Probably trying to align it all. So with the reports, trying to find and make sure you're capturing all of the different frequencies for the different subtypes of patients. So with your CKD on a particular drug that need it monitoring at 3 months as opposed to 6 months, it's that nitty gritty detail, which sometimes is a bit woolly as well.
Okay. And I can see the key benefits you mentioned: increase in productivity, actually streamlining things within the practice so that people can see patients more effectively, and definitely, an aspect when it comes to long-term condition care, but also in terms of prescribing safety. If you had to do it again, what would you have done differently?
We've probably tried to incorporate some of the visualizations into it. So it's relatively newish. I've personally not used it a huge amount. But I think there's some cool stuff that can be done with it to give the pharmacy team a bit more information. So the ones at the end point doing the review to then incorporate it into that part of the process.
Awesome. Thank you very much. So now we're going to move on to our next group. So that's now going to be bringing on Steve from Nottingham West PCN. Just a little bit of a tidbit for people. So Steve actually works fairly close by to me, considering I'm in Nottingham East PCN and he's in Nottingham West PCN. And we've had various chats around SystmOne, various other things over the past few years, having come across different aspects and stuff. Have you got your slides ready, Steve?
I have. Unfortunately, I'm on my Mac. It won't let me show them at the moment. I'm going to have to come off and come back on. So can you skip to the next?
I can jump around. So yeah,
to me while I just sort it out, and I'll come straight back on. Apologies.
No problem. Not a problem. So in that case, then we're going to switch over and we're going to bring on Robin. Hopefully, Robin's all set to go.
Ready to go.
Okay, so Robin's seeking. So just as soon as we've got a slight change in order, we've got Robin from Beacon Medical Practice, and I'm just looking for your slides, Robin.
We good?
We're good. And you're off. Off you go.
Hi, everybody. So I'm Robin. I'm the lead PCN pharmacist at Beacon Medical Group in Plymouth. So we've done a project or focused on this. We've all done lots of similar stuff to the other guys that have already presented today, and it's all great stuff. So it's fantastic that everybody's able to share it. So we're a fully merged single PCN practice covering 43,000 patients on the outskirts of Plymouth and the South Hams in Devon. We've got 7 sites, 180-ish staff, 19 partners, and a very varied multi-professional team of pharmacists, pharmacy technicians, paramedics, utilising all those skills of all of those, and of course, traditional roles: doctors, nurses, receptionists, administrators, and managers. So there's 3 main problems we've tried to tackle over the years with DOACs. So there's been a huge shift from warfarin to DOAC as preferred first-line treatment for most patients. Within that, we've also been told by the commissioner to shift from one DOAC to another. So this graph here is from Open Prescribing, where around 2022, 2023, we were told to switch everybody to a Doxaban. And then at the start of 25, we were told everybody to switch everybody back to Rivaroxaban and Apixaban. So that can create huge issues around these medicines that are quite complex and have some monitoring parameters that we need to keep an eye on. The goalposts have been constantly moving with DOACs as well. So we've gone from sort of the big pharma sell of you don't need to do as much monitoring for these new drugs. They're much safer and better than warfarin, to you only need to do it once a year. And then that changed to every 6 months. And now for high risk, frail patients, we're meant to be doing some of these tests and monitoring every 4 months. And the big one for many of us is that we shouldn't just be using eGFR for our dosing decisions of DOACs. We should be using creatinine clearance. So there was a really good paper in BJGP Open by the Open Safely team in 2024. And the summary is that most patients, sorry, not most patients, but a lot of patients hadn't had a creatinine clearance check in the last 12 months. And some of those patients now will need to have it done every 4 months. So we decided to tackle this. And sorry, there's also been lots of MHRA alerts around this and dosing DOAC safely. So when we started off with this problem, I started off with a great EGP learning video from a few years ago about action group descriptions. So what you can do with action group descriptions is put it on the actual repeat template screen when the creatinine was the Cockcroft galt was last done, and you can put that on the actual repeat template. So it should be a quick, easy win that when a pharmacist or a doctor is reviewing that medication, they can see when it was last done. And if it's not within the relevant parameters, ask the patient to book in to have that checked. Unfortunately, we're not very good at doing that. And we noticed when we did the second switch back, we have Ardens, there are pop-ups. I am not a big fan of pop-ups. I don't think they solve many problems. They might work for a bit, and most of us will just click away, and the evidence tells us that clinicians ignore safety warnings between 49 and 96% of the time. So trying to solve this problem or any other prescribing related problem that I try and tackle, I try and avoid pop-ups as much as possible. So what we decided to do, and we did this after we did the switch in February 2025, is create an e-workflow that will trigger a task we initially started off with when creatinine clearance is saved in the record. So that actually seemed to work really well. So what would happen is that e-workflow would trigger a task, you'd right-click that task, perform quick action, and then it would pop up a little template. We've got to click the right buttons to calculate the patient's creatinine clearance and then make the necessary dose adjustment if we need to. However, because this almost worked too well, when we've got lots of patients who are on DOACs, we've got about 1,400 patients. The vast majority of those patients are older, frailer patients, so about 900. We'll need this calculation done roughly every 4 months or so. And that was making a lot of tasks for us that we were having to, find time to do and then action any dose changes that need to happen as part of that. So one of the good things about SystmOne is there is a resource library, and you can actually use the protocols in SystmOne to do a bit of maths. So I didn't make all this myself. I copied it from the resource library and tweaked it. But what this calculation here does is working out the patient's creatinine clearance according to the Cockcroft-Gault equation. So where we have ended up now is that will happen automatically every time the serum creatinine is saved into the record by the person processing the pathology. It will calculate the creatinine clearance and just save that to the record without any user input at all in the front ground. So no pop-ups, no tasks, and that's massively reduced those numbers of tasks. So the people who are overdue a weight or who are underweight or overweight, it will still trigger the task so somebody can have a bit more time to actually chase the patient up for a weight, etc. We also have built in a protocol that goes to our prescription clerks if weights are overdue or if blood tests are due, and our prescription clerks will invite them in. And this has made a dramatic change to the number of patients. When we did that switch in February 2025 from edoxaban to rivaroxaban or apixaban, we probably had about 900 patients who hadn't had their creatinine clearance calculated in the previous 12 months. And now that's dropped to around 100. So and the iterative improvements here, and I think that's the good thing about all of the things people have demonstrated today, is you can just constantly build on a protocol or a template or a workflow to make it better over time, and that's hugely reduced the manual workload we have for the pharmacy team calculating creatinine clearance. And we're now spending the time similar to what Will's pharmacists have been doing, using pharmacist and pharmacy technician time to speak to patients, where they can add a lot more value when the computer can do this in the background for us. So next steps are, so at the moment, now that we are pretty robust at calculating creatinine clearance, we were just working off the Ardens reports that will find the patients who might need a dose adjustment. Whereas my next addition to this e-workflow, I'm going to try adding in a next step to the protocol where it will task us to say, this person might need a dose adjustment, please book them in with a pharmacist. And that's it for now. Thank you.
Thank you very much, Robin. Whistle stop tour of what the work that you've been doing. And, I kind of wish I could vote for a winner based on the kudos of my own videos being in that particular thing. But the opportunity that goes to our viewers, not to myself. So don't worry, there's going to be no nepotism whatsoever in the allocation of this particular award. However, how did you find that process? And in particular, which part of that workflow did you find most interesting? And I'm particularly keen to know about the e-workflow use, because that's the one that I haven't seen somebody use so far.
So I think it was the shift. So an e-workflow is basically like a fancy task. And I think it was the ability of being able to right click. So with a task, you have to open up the patient record. You might launch another template, whereas with an e-workflow, you can launch straight into the template. So that's why I decided to use workflow for that. I think the bit that was most challenging was tweaking that formula at the end to make sure the calculation was accurate. So I was comparing it with the SystmOne inbuilt calculator, an MD calc, and also good old Excel spreadsheet to make sure the maths was adding up. And I think that's the other great thing about SystmOne is you can layer that. So I started off with that calculation just being on a button that I could click, and then have the SystmOne calculator up there as well. So yeah.
And which particular part did you feel, if I had to do it again, this is how I do it differently?
I think probably I would try and skip to the end a little bit more now. So if I was trying to design something similar again, I don't think I'd need to go through this iterative process of, okay, we've got a protocol with a big list of patients and we'll go through them one by one. Okay, we'll change that to a task. Okay, now we'll just automatically calculate it. So I think now I've got the understanding of protocols a bit more from playing around with it. I try and do that as a one-er.
And what's next on your hit list?
I don't know. So we've got, similar to the other guys, we've got some protocols around lipid management. CKD is probably the next one for us around coding that appropriately. So I think we're working up a project where we will be trying to reduce the sort of missed CKD coding and having to do a bit of a catch up once or twice a year.
Awesome. Thank you very much. Right. So now we're going to jump. I took the wrong person off, didn't I? There we go. Apologies all. So, Steve, your slides are up. Your time starts now.
Fantastic. Thank you. And apologies for my earlier Mac being a bit content sensitive on this incognito window. I think it's interesting. Robin and I maybe should have had a little chat because it sounds like we've done some very similar things actually. So I'm Steve Murdoch. I'm the IT data transformation lead for Nottingham West PCN. We're a PCN of 12 practices with a population of around 110,000 patients. And I'm going to show you how we also managed DOAC management using the SystmOne tools with an automated creatinine clearance calculator. But it's interesting with the work that we've just seen from Robin, how we've divulged slightly in the ways that we've done it. So our target for this very specific piece of work was to tackle the real patient safety problem of making sure that patients have got an up-to-date and really importantly an accurate creatinine clearance calculation in line with our Nottinghamshire prescribing guidelines. And we wanted that to happen at the point of the clinician reviewing a pathology result and for the whole process to be really light touch. So, as I mentioned, it's a significant problem. DOACs are high-risk meds, and obviously the MHRA has highlighted ongoing reports of life-threatening bleeds. The correct dosing depends greatly on the renal function, and we need that creatinine clearance. In our research, a British Journal of General Practice study of around 20 million patients found that amazingly 43% of AF patients on DOACs had no creatinine clearance recorded at all. Within our own PCN, we found multiple issues of using either outdated weights in patients who haven't got a weight recorded, confusion around when to use the actual or adjusted body weight, and then also with the addition of the new 4-monthly monitoring for the over 75s or the severely frails, practices getting that recall schedule correct. So what did we do? So we built a series of protocols. Obviously, there's lots of work underlying that for SystmOne clinical reports. And it fires at the pathology review when a creatinine result is reviewed. And then it does two things. Firstly, it will go off and check for a weight. So if there is a wait in the last 12 months, then it'll proceed to do the calculation. If there isn't one, then we'll automatically send a questionnaire to the patient, either on email or our fallback is SMS, with a, as I say, a SystmOne questionnaire that the patient can complete and then just send that back to the practice with an up-to-date weight. If there isn't, if it doesn't get sent or the patient doesn't send it back, we track those on our dashboard, which I'll show in a minute. It then proceeds, if the patient has got a weight, it'll then proceed to do the automated creatinine clearance using the Cockcroft Gold with the various corrections. So I'd imagine that ours and Robin's protocols look very similar. And those first 3 protocols are all hosted from our PCN hub unit and pushed out to the practices. But then what we also do is, because of the way that we code the information into SystmOne at that point, we're able to create a bespoke local practice protocol, which we call the kind of so what? What do you want to do with that information now that you've got it? And most practices actually just want a task to their internal pharmacy teams to action those and to review the DOAC dose. The calculator itself, we've built quite a lot of smart tools into it. So not only does it, of course, need to align to the SystmOne inbuilt calculator, but it also needs to adhere to our local Nottinghamshire APC guidelines around BMI over 40 or weight over 120 kilos. And it'll also detect if the patient's got AF or whether it's DVT. From a governance and safety perspective, we identified quite early that there was a potential for this to be sort of classified as maybe a potentially software as a medical device. So we just wanted to make sure that we've gone a sort of belt and braces approach around our user acceptance testing, hazard log, and mitigation of risk, because it is putting information straight into the GP record, notwithstanding that those patients are reviewed shortly after. So a couple of bits of documentation that we've done. So obviously we've adhered to the DCB 0160 clinical safety guidelines. We've done a health institution exemption document within our PCN that will cover our practices. And it's been signed off by the various bodies within our PCN. And then we've also done user acceptance testing as well. So we've got 20 out of 20 patients with various scenarios of ages, weights, whether AF and VTE. We also look for things like weights that aren't recent for elderly patients, because there's not really much point calculating something on a patient that's not been, the height hasn't been measured for 20 odd years. How's it been effective? It has been really effective, actually. So we've just done a 2-month pilot really in one of our practices, and you can see it's really amazing, really. The contemporaneous creatinine clearance recording after the blood test has gone up by 22% in 2 months. And the practice were already doing a pretty good job. There's also an 18% increase in the patients who've had all of the monitoring that's required for their recall. And in terms of weight recording, the practices were already doing really well anyway, so they've just maintained that. So well done to them. So what does it look like? So we've got 2 key bits of SystmOne really. We've got a data visualization dashboard. The green section at the top of this screen is for the admin to use, and that shows all of the various recall schedules. And it's broken down by patients who are due, overdue, and very overdue, so they can target patients. And then also the patients who haven't got the weight recording or have been sent the questionnaire and haven't returned it. The bottom section of this screen is for some local reports that we've got around the DOAC dose that the patient's on, and whether or that might need adjusting. And then also we've linked it into the interactions guidance that the APC have published, so that it's all available for the pharmacist on one screen. And then we've also got some performance monitoring. So as you're working your way through this, you can see how you're doing. We've also devised a SystmOne interface within the record as well, using a visualization. So this pulls all of the information that the pharmacist would have previously hunted around various parts of the record for. So which DOAC are they on? What's the indication for it? What was their most recent weight? What's their latest creatinine clearance? And what's the delta against their previous one? And also on this screen, we can show additional information outside of this that might be pertinent to act upon during that review. So things like any CQC alerts or any other additional blood tests that the patient might be outstanding for. So what's coming next? So we're going to roll this out across all of our Nottingham West PCN practices, and it's going to be used by our internal PCN clinical pharmacist team as well. It is fully shareable. It would need to be rebuilt within practices, but the building blocks, the Lego bricks, effectively are there, and they could be given to a data lead within a PCN or a practice to reconstruct it. And then we'll also look at the potential to scale that across our local ICB footprint and wider. And that's me. Thank you. I'm happy to take any questions.
Thank you, Steve. Really awesome. And I can see already comments from Robin saying that it seems prettier than his. So he's commenting from there. You mentioned, obviously, the diligence you've done in terms of the calculation side of it, and particularly that aspect of it being considered a medical device. If that was to be shared with other places, how much work would you feel they would need to consider in terms of doing that aspect of the digital governance?
I would expect that they would probably still need to go through the initial sort of what I would call the baby steps. So our initial steps with the practice were that we wanted it to end up light touch, so no one really needs to see anything. But actually, at the very beginning, you do need to see everything. You need to see exactly how what result has been arrived at, how it's been derived, and if the clinician agrees with it. And if they don't, then back to the drawing board and examine your protocol.
Okay.
Once you've gone through those steps, I think you can rebuild it quite easily.
Okay. What did you find the most challenging part of the work that you did?
Sorry, just say that again.
Sure. What did you feel? Yeah. What did you find the most challenging part of that particular work that you did? You getting me coming through?
I don't know whether it's my connection, but I can't.
Can you hear me all right, Steve? Hello? Apologies all. I think we've got some connection issues going on here, so sorry on that. So, Steve, I don't know if you can hear us or not. No, it doesn't look like so. Okay. Thank you, Steve. I'm just hoping you can see me. If not, I'm just going to take you off as we finish off from there. So thank you, everybody, for joining us for this session. So as we mentioned before, you have the opportunity to vote, and this is for now the Gold Standard Prescribing Award. If you do want to vote for that, I have already put the links down below in the comments and stuff. So if you go to that web link that you can see there, that will also be available on the chat, as well as on the pinned comments for if you're watching us on YouTube and various other platforms as well. And your opportunity to vote for your winner for each of those two awards, that's the Long-Term Condition Awards and the Prescribing Awards. Just a reminder, for the Long-Term Conditions Awards, we've got King's Medical Practice, we've got Riding's Medical Practice, and we've got Bytes PCN. And then for the Prescribing Award, we've got Topsham Surgery, Nottingham West PCN, and Beacon's Medical Practice as well. Make sure you also do join us in a month's time when we are going to be showcasing the winner from this particular award. But also, in addition to that, our next awards in terms of innovation that's happening within general practice, and the opportunity to nominate either yourself or other practices are doing some amazing work. And the links for those are there. So you can submit your entry using that left QR code. You can vote, as we've already said, with the QR code that's on screen, or the link in the chat and the comments. Or if you want more information, feel free to have a look at that, and your opportunity to win that £1,000 award money and the kudos of basically owning these awards and stuff. Hope you found this really useful. If you do want to catch up with more content on the channel, then make sure you do have a look at this video coming up right here, which is going to be that next episode. Alternatively, if you want to go back and watch the Triage and Access one to see some of the information that's been showcased, then have a look right here. And as ever, we'll be here to take and answer your primary care and learning. We'll catch you.